On behalf of the American College of Cardiology and the Center for Systems Improvement, I'd like to welcome you to the EMS and Systems of Care webinar series, taking quality to the next level. I'm Tim Phalen. I will be one of your moderators, along with Tom Bouthillet. And as you see on the slide here, Tom is quite busy, quite distinguished. He's the battalion chief at Hilton Head Fire Rescue in South Carolina. He's the program director for the South Carolina Resuscitation Academy. That's this high-performance CPR working group on the editorial advisory board for EMS World. And where I got to know him most, or at least second time I saw him, I guess, was as his role as the founder and editor of EMS 12 Lead. And the short version is, if you have any interest in ECGs or resuscitation and you own a computer, you have no doubt seen and benefited from a lot of Tom's work.
Thanks, Tim. And for those of you not already familiar with Tim, which is probably not many of you, he is the principal at ECG Solutions, author of 12-lead ECG in acute myocardial infarction, co-author of the 12-lead ECG in acute coronary syndromes, and has provided 12-lead education to over 100,000 providers in the United States, Canada, and 11 other countries. And you may not know this, he was a Cub Scout and a Weeblo, and is beloved by children and elderly women all over the land.
Everywhere. So, well, thank you, Tom, I think. So, this is the third module of the webinar series, and we'll be structuring your system for quality. But before we start up, here are a couple of housekeeping details. Part of the webinar will be a video that appears in a pop-up window. Some of the people had some issues with that. So if you experience any problems with that, if you have trouble seeing the video, you may need to disable a pop-up blocker in your web browser. So if you're having trouble with the video, it is a pop-up, so you might need to disable the pop-up blocker if you have one of those set.
If you're watching this live at any time, please feel free to enter any questions or comments you might have into the question box in GoToMeeting. Tim and I will select some of them to answer on air as time permits during the Q&A portion of the webinar.
So if you're watching the archive version of this, which will be available in a few days, you will still, if you're watching this recorded, you can still send in questions and comments to Mick. His email is mick@improvethesystem.com. And for anybody who's listening right now, you could be aware that archive recording will be posted in a few days, and he will just do his best to respond to any of the questions or comments that are sent in via email.
Presenting today's webinar is Mic Gunderson, President at the Center for Systems Improvement. Mick has a long and diverse background in EMS, quality, and cardiovascular care. He has been involved in emergency healthcare for over 40 years in various leadership, managerial, and frontline clinical roles. And I've already learned a tremendous amount from the first video in this webinar series. So Mick, I really appreciate all of that. We're already starting to think in terms of ad hoc improvement teams and clinical specialty teams on Hilton Head Island, and we're already seeing some benefits from that. So thank you very much.
Thanks, guys, for being here, and thanks, Tom, for your kind introduction. We're going to start the video segment right away, so please bear with us for just a moment while we get that started. This EMS and Systems of Care webinar series is supported by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. Later this year, they'll be rolling out a new service that takes support to EMS and Systems of Care quality improvement efforts for acute myocardial infarctions to a new level with NCDR eReports EMS. More information is available at acc.org/eReports EMS. For this third module in our series on taking clinical quality to the next level, we'll start out with a very brief recap of some of the content from the second module, which was on structuring your organization for quality. Many things we discussed there about the organizational structure will directly relate to what we'll talk about here for the structure of systems. If you'd like to watch that entire webinar, you can access all of the webinars archived from this series at acc.org/eReportsEMS. Just scroll down to the resources section of the page. Now, in Module 2, we talked about how healthcare provider organizations often have just one person taking on most of the responsibility for managing clinical quality. In hospitals, it may be one person per clinical service line, but for EMS, it's often just that one person who frequently has a title of something like the clinical or quality manager. Now, after that person has collected and cleaned data for some standard reports, investigated and resolved clinical incidents and complaints, addressed clinical training and recertification issues, as well as any other duties as assigned, there often isn't much time at the end of the day left to do actual improvement project, and that creates a bottleneck in the whole quality improvement effort. We then talked about how EMS could help alleviate the bottleneck by implementing a team-based clinical quality model that utilizes clinical specialty teams supplemented by ad hoc improvement project teams. We talked about how a clinical specialty team takes stewardship of a particular clinical area, monitors its performance, stays abreast of the current research and best practices, and then makes improvement project proposals to the senior management team. Those clinical specialty teams consist primarily of frontline staff that share a passion for that particular clinical area. Now, once an improvement project proposal is reviewed and approved by the senior management team, the improvement project is carried out by the ad hoc improvement project team. Those teams also consist primarily of frontline staff that would like to participate in getting a particular project completed. It also gives the frontline staff an opportunity to influence how the organization operates. After that project is completed, the ad hoc project team is disbanded. This approach gets more of the frontline workforce directly involved in the quality program and starts grooming people to move up into a clinical specialty team. Here in this third module of our series, we're going to shift from a focus on how you can structure your provider organization to improve quality to a focus on how to structure your entire community or regional system for quality, with an emphasis on how this applies to high-risk, time-sensitive systems of care. So let's start by clarifying exactly what we're talking about when referring to systems and systems of care for time-sensitive emergencies. One of the best explanations of a system and systems thinking I've ever heard is from the late Russell Ackoff, one of the giants in the field of systems theory and thinking. I'm going to show you an excerpt from an extraordinary lecture he gave, and you'll see what this has to do with a car and its parts in just a few minutes. On the other side, we'll talk about how all of this relates to EMS and systems of care for high-risk, time-sensitive conditions.
The hypothesis that I want to set forward to you is the reason for the failures is primarily the fact that they have not been embedded in systems thinking. They have been anti-systemic applications. Now let me try to explain what that means. First, what's a system? A system is a whole, spelled with a W, that consists of parts, each of which can affect its behavior or its properties. You, for example, are a biological system called an organism, and you consist of parts, your heart, your lungs, your stomach, pancreas, and so on, each of which can affect your behavior or your properties. The second requirement is that each part of the system, when it affects the system, is dependent for its effect on some other part. In other words, the parts are interdependent. No part of a system or collection of parts of a system has an independent effect on it. Therefore, the way the heart affects you depends on what the lungs are doing and the brain is doing. The parts are all interconnected. And therefore, a system is a whole that cannot be divided into independent parts. Now, that has some very, very important implications that are generally overlooked. First, the essential or defining properties of any system are properties of the whole which none of its parts have. For example, a very elementary system you are familiar with is an automobile. The essential property of an automobile is it can carry you from one place to another. No part of an automobile can do that. The wheel can't, the axle can't, the seat can't, the motor can't. The motor can't even carry itself from one place to another, but the automobile can. You have certain characteristics, the most important of which is life. None of your parts live. You have life. You can write. Your hand can't write. That's easy to demonstrate. Cut it off and put it on the table and watch what it does. Nothing. You can see, your eye can't see, you can think, your brain can't think. And therefore, when a system is taken apart, it loses its essential properties. If I bring an automobile into this room and disassemble it, although every single part's in this room, I don't have an automobile. Because the system is not the sum of the behavior of its parts, it's a product of their interactions. And that's been said here in many ways over and over today. Now, what does that mean? If we have a system of improvement that's directed at improving the parts taken separately, you can be absolutely sure that the performance of the whole will not be improved. And that can be rigorously proven. But most applications of improvement programs are directed at improving the parts taken separately, not the whole. The proof is complex, and I won't bore you with it. Let's just take a simple example. I read in the New York Times recently that 457 different automobiles are available in the United States. Let's buy one of each and bring them into a large garage. Let's then hire 200 of the best automotive engineers in the world and ask them to determine which car has the best engine. Suppose they come back and say the Rolls-Royce has the best engine. You make a note of it. Which one has the best transmission, we ask them, and they go run tests and come back and say the Mercedes does. Which one has the best battery? Come back and say the Buick does. And one by one, for every part required for an automobile, they tell us which is the best one available. Now we take that list, give it back to them, and say remove those parts from those cars, put them together into the best possible automobile. Because now we'll have an automobile consisting of all the best parts. What do we get? You don't even get an automobile, for the obvious reason that the parts don't fit. The performance of a system depends on how the parts fit, not how they act taken separately. You see, the architect, who's the profession that I think understands systems best, really has the fundamental idea. When a client comes in to see an architect, and they say, I want to build a house for my family with 3 bedrooms, a living room, dining room, and kitchen, a family room, a 2-car garage. I want it on 1 floor. I'd like it to be built out of redwood, and I don't want it to cost more than $10,000. What does the architect do? He has a set of properties that the client wants. Does he sit down and start to design the kitchen, and then the living room, and then the bedrooms, and then the garage? Is that what he does? Of course not. What he does is produce an overall design of the house. Now he produces designs of the rooms to fit into the design of the house. But he discovers in the process that he can modify the house in such a way as to improve the quality of the rooms. But he will never modify the house to improve the quality of the room unless the quality of the house is simultaneously improved. And that's fundamentally the principle that ought to be used in continuous improvement.
That's such an amazing talk. To let you explore systems thinking in a bit more detail, here's a link to a page with some additional content. The page also has a link to the complete lecture by Dr. Akoff. So like a car, a system of care has many parts, and we'll use STEMI systems of care for the example here. That system includes all types of EMS agencies, emergency departments, cardiac cath labs, hospital cardiac wards, and even cardiac rehab centers. One of those parts, on its own, does not have the essential property of a STEMI system of care, the ability to reduce the acute morbidity and mortality from STEMI across an entire community or region. When we think about finding ways to improve STEMI care, or care for any other high-risk, time-sensitive condition, it's important to consider all of the parts of the system of care. And one of the key points that Dr. Akoff makes about systems is that if you focus on optimizing the parts and don't factor in the impact of those parts on changes in the system as a whole, you can actually decrease system performance rather than increase it. He emphasized that the performance of a system is not equal to the sum of the performance of its individual parts, but is equal to the product of how those parts interact with each other. As a very simple example, imagine if we tried to optimize the field diagnosis part of a STEMI system of care without regard for the systemic impacts. We could run all sorts of additional diagnostic tests in the field to make a much more accurate field diagnosis before a decision is made to call a STEMI alert from the field. That EMS optimized approach would improve the accuracy of EMS STEMI alerts, decreasing those pesky and expensive field cath lab activation overcalls or false positives, and decrease the frequency of those unfortunate missed opportunities for field cath lab activations, the false negatives. However, without consideration of the impacts of any such change in that field diagnosis part on the overall system of care for STEMI, we would end up spending a lot more time in the field, which would suboptimize overall system performance by causing significant delays in getting patients into the cath lab to reopen the obstructed coronary artery, and that would diminish the performance of the system as measured by its ability to reduce morbidity and mortality from STEMI across the entire community. So the point is that we need to recognize the essential property or purpose of a system so that our efforts to improve performance of any of the parts do not compromise performance of the overall system. We want those changes at a component or part level to improve overall system performance, not detract from it. This is one of the reasons why a systems thinking perspective in healthcare quality and value improvement can be so helpful. For these same kinds of reasons, taking a more formal approach to designing the structure and operations of a system of care can yield significant benefits. As another example, before things started to significantly change 10 to 15 years ago, many cardiologists were inadvertently sub-optimizing the STEMI system of care, albeit it was not a formally designed STEMI system of care back then in most communities. It wasn't uncommon for cardiologists to insist on seeing the patient and the 12-lead ECG themselves before authorizing activation of the cardiac cath lab. Their intentions were noble. They were trying to optimize use of a scarce and expensive resource. But it was systems thinking in action that spurred the American College of Cardiology's Door to Balloon initiative and the American Heart Association's Mission Lifeline program to advance the idea that emergency physicians be allowed to activate the cath lab. That same sort of systems thinking continued with the notion of EMS being properly equipped, trained, and empowered to declare STEMI alerts from the field so that the cath lab could be ready to initiate care much sooner. We see that systems thinking continuing today with the notion of EMS taking patients directly to the cath lab with little or no time in the emergency department when appropriate criteria are met and there's an effective QI program in place. But all too commonly, there isn't the venue where all of the provider organizations along the continuum of care for high-risk, time-sensitive conditions like STEMI can get together to talk about system performance issues and work collaboratively on QI initiatives to make the overall system better. Everybody tends to work in their own silo, and that's what fuels the sort of sub-optimization we've been talking about. But if you think about it a bit deeper, it's not particularly surprising that this sort of thing happens. We commonly see some sort of accountability for performance within an individual hospital or an EMS agency, but there's little to no accountability for their actions at a systems of care level. So people will have a tendency to optimize the part of the system that they each are accountable for, inadvertently with less regard for the systemic impacts. The system level impacts might not even be explicitly measured. But let's be candid. Bringing the right people together from the various parts of a system to reach an agreement to work collaboratively towards making systems level improvements can be quite a political and logistical challenge. It's usually not very easy to get all of the right executive level decision makers into the same room at the same time from competing hospitals, ambulance services, and rival government-operated provider organizations to have some often difficult but necessary conversations. Those difficult conversations for 911 communication centers, ambulance services, and fire rescue agencies might be about things like establishing closest unit response policies that disregard jurisdictional boundaries for the most high-risk time-sensitive cases. Agency interests in preserving their call volumes, revenues, and jurisdictional sovereignty can be real barriers, and sometimes just plain old institutional ego and resistance to change can get in the way. Difficult conversations for hospital administrators might include things like ambulance destination protocols, which might have one hospital bypassed in favor of another. This can be especially difficult when those patients have conditions associated with significant revenues. The point is that these conversations need to take place in order to improve the system, however difficult they may be. We saw that years ago with surgeons advocating for better trauma systems. We've seen it with advocacy from EMS leaders for formally establishing systems of care for out-of-hospital cardiac arrest. In the last several years, we've seen it with STEMI and stroke. And more recently, we're starting to see it more and more often with sepsis. It's not an easy lift. Sometimes, the EMS medical director for one of the EMS provider organizations takes on the challenge of being a systems-level care champion. This often happens because EMS has to constantly deal with systems issues in their role of connecting patients to multiple hospitals. But sometimes that EMS medical director is also an ED physician, and they need to be careful about getting caught up in real or perceived conflicts of interest in developing destination protocols or other policies that could have a negative impact on the hospital where they work or their competitor hospitals. These kinds of issues can tend to shy physicians away from taking on these sorts of third-rail political issues by themselves. If there is a system-level EMS medical oversight agency, one that has authority for the overall EMS system, including emergency medical dispatch, non-transport medical first response, and ambulances rather than just one EMS provider organization, those agencies are sometimes in a much better position to convene the parties across the community or region to address systems of care issues. Sometimes the catalyst for convening all of the relevant stakeholders is negative publicity from a bad outcome. A patient dies or suffers harm for lack of appropriate policies or protocols at a systems level. An investigative reporter from the media might call EMS or hospitals out on such issues. Nationally, just look back on the series of articles back in 2003 in USA Today by Bob Davis on the deficiency in systems of care across the country for cardiac arrest. These kinds of events, while tragic, can provide unique opportunities to move a system of care effort forward that might have been stuck in the mud by political resistance to change. But in the wake of the publicity from a bad outcome, there's often more political will to make changes. Things are more apt to change, but only for a limited amount of time, and that's because of the immediate pressure of public opinion wanting to see things change sooner than later. If the community is lucky, at least one of these scenarios leads to the convening of a group of executive-level decision makers who can make commitments about the topics that these often difficult conversations need to address, and commit their organizations to actively participate and support having ongoing meetings at a more operational level for systems-level quality improvement and policy-making efforts. So let's suppose that you're able to get all of the right executive-level decision makers in the same room at the same time. A key to moving those difficult conversations forward is to have everyone agree to one important ground rule, that decisions be driven first and foremost by patient and community interests. You might start off with an acknowledgement that there will be some difficult issues they need to address that can impact everyone's financial and political interests. With acknowledgement of that reality, the group can come to the realization that the most ethical and politically defensible position to take is that patient and community interests in decision-making need to supersede any individual provider organization's financial and political interests. Doing anything short of that will not pass a sniff test. The second element of the conversation, which can be introduced in the invitation to attend the meeting, is the scope of the initiative. To avoid squandering the opportunity to make as much progress as possible, consider using this opportunity to address the full scope of high-risk, time-sensitive conditions. Not just STEMI, not just stroke, not just trauma or sepsis or cardiac arrest or pulmonary embolism. There are lots of issues in common across these high-risk, time-sensitive conditions. EMS destination policies, closest unit response, cross-organizational and cross-disciplinary real-time communications, and the list goes on. Therefore, it doesn't make sense to have systems of care meetings for each of the time-sensitive conditions separately. Such silos are counterproductive. There should be a time and place to address the common issues collectively across clinical domains, and a way to address condition-specific issues separately. And there should be a way to effectively cross-pollinate ideas and solutions across these high-risk, time-sensitive conditions. We should try to come to an agreement with all of the executive-level decision-makers in the room that they will establish a group that will regularly meet for systems-level coordination and QI. This will be the venue where issues in high-risk, time-sensitive care are addressed collectively at a systems level for the benefit of the patients and communities that their organizations serve. This group will, in essence, become a coalition. It should have representation from 911 communication centers, non-transport medical first response agencies, ambulance services, EMS regulatory and medical oversight agencies, and hospitals to include their emergency departments and acute specialty care services. Ideally, it should also include post-acute care rehabilitation and secondary prevention to some degree to make sure that all of the efforts in the acute phase do not end up for naught because the STEMI patient, for example, was discharged from the hospital and didn't receive or take their platelet inhibitor meds. And as a result, the shiny new stent quickly clogs back up and provokes another life-threatening STEMI. Or they fail to get referred into cardiac rehab to help reduce and mitigate risk factors to prevent future major acute cardiac events. Ideally, the consortium would also include major payers who bear the responsibility for paying for all of this care and would therefore be a financial beneficiary from a more effective and efficient system. Those financial benefits could be shared with the provider organizations through so-called alternative payment models. In this way, the consortium can take responsibility for making systems-level improvements for the full spectrum of high-risk, time-sensitive conditions and find ways to better align the clinical interests of patients with the financial interests of providers and payers. If you saw the prior webinar on structuring your organization for quality, you might recall a diagram of an organizational structure that had a senior management team providing leadership, direction, and feedback to a set of EMS clinical specialty teams. Each of those clinical specialty teams took stewardship for moving care forward in their respective clinical domains. The senior management team makes sure efforts between the clinical specialty teams are well coordinated and align with the organization's strategic priorities. There can be a strong parallel at a multi-organizational, time-sensitive care coalition level. The executive-level decision makers from the various organizations can constitute a steering committee for the time-sensitive care coalition, just like the senior management team does at an EMS organization level. At a systems level, we could have condition-specific committees for each of the conditions that the steering committee has decided to take on. These are similar to the clinical specialty teams at an EMS organizational level. The time-sensitive care coalition might not take on every condition all at once, but at least there is a venue where the community or region can address any given time-sensitive condition when they're ready to do so. They might start with one or two conditions and then add more over time. In many cases, the community or region might already have separate systems of care committees for some of the time-sensitive conditions, maybe trauma and STEMI, for example. So instead of these groups continuing to operate in silos, they're brought into the consortium. They can retain their general structure and control of their projects, but should agree to address issues that are common across multiple conditions in collaboration with the other time-sensitive condition committees, and share their knowledge and experience to improve things across the board. Perhaps the process that the STEMI committee developed for pre-activation of the cardiac cath team can be adapted for stroke. Perhaps the process developed by the stroke committee for taking EMS patients directly to the CT scanner could be adapted for taking STEMI patients directly to the cardiac cath lab. Perhaps the trauma committee has determined how to appropriately balance overcall and undercall rates. That can be applied with appropriate adaptation by the STEMI and stroke committees. The meeting logistics for this multi-condition model may get a bit simpler as well. Instead of EMS and emergency medicine in particular needing to go to separate meetings on separate days in separate locations for each of the time-sensitive condition meetings, there could be just one larger meeting of a steering committee followed by the condition-specific subcommittee breakout sessions. At the local time-sensitive care consortium steering committee meeting, each of the time-sensitive condition subcommittees would very briefly summarize their current performance level, the results of any of their QI projects, and propose new projects that might encompass other time-sensitive conditions. This creates an opportunity to leverage what was accomplished in one subcommittee and apply it to the other time-sensitive conditions. In order to get EMS and emergency medicine representation in each of these breakouts, more than one person from EMS and emergency medicine will need to attend, which is also part of the point, to get more people involved and to simplify the meetings themselves by consolidating things where it makes sense to do so. Ideally, from each EMS provider agency, someone from that agency's clinical specialty team would attend the corresponding subcommittee meeting at a systems level. For example, someone from the EMS clinical specialty team for cardiovascular care or acute myocardial infarctions would be the one to attend the systems level STEMI QI committee meeting. Each hospital would send someone from their STEMI committee to the systems level STEMI committee meeting. With this crossover between EMS provider agency and hospital QI committees on the corresponding systems level committees, it becomes much easier to coordinate projects and aggregate data at all levels. While this is old news in most systems, consider how the rollout of 12-lead transmission from the field to hospitals might be coordinated through this kind of structure. EMS agencies would let the consortium STEMI subcommittee, which already has all of the hospitals represented, know what monitor defibrillators they use and what their existing ECG transmission capabilities and technologies might be. Hospitals can then look for 12-lead receiving stations that work with all of them. Hospitals might also consider working together through the consortium to make a bulk purchase in hopes of getting a better deal. Perhaps one of the technology options provides 12-lead transmission for STEMI in addition to telemedicine data on stroke cases. In that case, the consortium can readily bring in its stroke subcommittee into that decision-making process. The point here is that these types of systems and organization-level QI program structures can make all these sorts of initiatives and decisions much more efficient and effective for all parties involved. Now, some improvement projects will have to be implemented within each provider organization. The idea for a project might come from the systems level subcommittee, but it gets implemented by each provider agency in its own way. For example, field cath lab activation policies, direct-to-cath lab or CT scanner protocols, 12-lead transmission processes, and ePCR to hospital data connections are all projects where each individual hospital and EMS agencies will have their own way to operationalize them within their respective institutions. For EMS in particular, it will be extraordinarily helpful for hospitals to standardize how EMS interacts with them. While each hospital may have their own twist internally on how they activate their cardiac cath lab teams during and outside of their regular operating hours, the way EMS communicates a STEMI alert to hospitals should be uniform across all hospitals. Having communications and data aggregation platforms at the hospitals for data and voice that do not work across all of the EMS agencies and referral hospitals suboptimizes the whole system. Again, these sorts of things can be coordinated at the systems level by the Time-Sensitive Care Coalition. Similarly, ideas for improvement may come up at the organization level, but they may really need to be implemented at a systems level. So there will need to be a little bit of triage to determine where to do a given QI project at an organizational or at a systems level. For example, an EMS agency's clinical specialty team may have an idea for improving public education in stroke recognition. This is a systems level issue. While that one EMS agency could do some public education on its own, it would be more powerful for all the EMS agencies and hospitals to work together with all of the local media outlets. Together, the system is much more likely to be successful in undertaking the project in a way that makes a measurable impact versus one agency working on its own. So it will become a project for the stroke subcommittee of the Time-Sensitive Care Coalition, rather than just the one EMS provider agency. Conversely, the systems-level out-of-hospital cardiac arrest subcommittee might suggest that all the EMS agencies and emergency departments start using metronomes to improve compliance to target compression and ventilation rates. While the systems level committee might have suggested it, it has to be implemented on the front lines by each individual EMS agency and hospital, making it a project for their internal EMS clinical specialty teams and internal hospital service line QI committees to take on. The great news is that this sort of multi-condition consortium building for time-sensitive care is already happening in many communities across the country. We see mature regional trauma systems of care stretching their infrastructure to take on out-of-hospital cardiac arrest. We're very commonly seeing STEMI systems of care expanding to take on stroke. Perhaps the most common scenario for establishing multi-condition systems of care is with community-wide or regional EMS oversight agencies. Examples include local EMS agency or LEMSMAs in California, regional advisory councils or RACs in Texas, medical control authorities or MCAs in Michigan, and that's just scratching the surface. These groups are inherently designed to facilitate collaboration in efforts to organize and improve care across all of the 911 centers, non-transport medical first response agencies, ambulance services, and hospitals in their community or region. In some places, particularly at a state level, we see health departments involved in establishing and facilitating systems of care for time-sensitive conditions. Classically, public health departments are involved in trauma because trauma and the other high-risk time-sensitive conditions require resources and coordination that span the community. They really are public health issues. Consequently, public health agencies have much they can bring to the table to improve systems of care. I'd encourage you to reach out to your local public health officials as a resource to be part of your time-sensitive care coalition. For that reason, one of the organizations that the ACC is partnering with to promote this model is the National Association of County and City Health Officials. In fact, at the annual meeting on July 9th in Orlando, NACCHO and the ACC will be putting on a pre-conference workshop to train public health officials and other interested parties on this time-sensitive care coalition model. For anyone interested in more information on this opportunities, details will be posted soon at nachoannual.org/home. So at the end of the day, what we're advocating here is to really embrace the opportunity to take a systems approach to the full spectrum of high-risk, time-sensitive care conditions. Organize your entire community or region in a way that maximizes its opportunities to improve quality. I hope this has you thinking about how to catalyze these kinds of changes in your community. If your community is already working along these lines, think about how the impact might be taken up a notch or two by establishing a time-sensitive care coalition with condition-specific subcommittees and catalyzing the development of organization-level clinical specialty teams in your EMS agencies and hospitals. So let's switch back to the live stream for questions and comments.
Well, if you are watching this live, here's your opportunity. If you would type in your questions and in the comments in the question box, and then Tom and I will be able to read through them and we'll address them here in the time that we have remaining.
If you're watching the archive recording of this webinar, please feel free to send questions and comments to Mic, that's MIC, at improvethesystem.com. The archive recording will be posted within a few days after the live session with an email notice and viewing link sent out to everyone who registered for this event. Mic will do his best to respond to questions and comments sent in by email.
All right. Well, while we're waiting for folks to submit some questions, I got something for you, Mic. So I think part of the issue, just as humans, there was so much good information in this one as there was the last one. There's the category of, well, Mic said it, does that mean we all caught it? All righty, so maybe you could hit on something for me. And I know you addressed it in the video, but if you could just kind of like shine a light on this. The last session was all about an organizational approach. And I think people really connected with that. And it's like, wow, there's a whole bunch of stuff that I can start doing right now. And we had tons of questions. Now today, and I love that little analogy on the car and the parts and trying to put the best engine with the best transmission. So obviously, one of the primary messages from today is that we need to look at things from a more holistic point of view and look at it from a system perspective. So even though you began to address it, why don't you just take a few minutes to kind of connect those dots? So like, how would somebody decide, oh, hey, here's something that's appropriate for us to address at the organizational level, but maybe something else would not be appropriate and that would really be better addressed at the system level?
Yeah, no, it's really the crux of of the webinar, the point you raised, Tim, and deserves reemphasis. And that's what I was trying to get at with the business triage. If you think about what the given issue is, you have to think through, is this best implemented internally within each of the individual organizations, or is it best for us to do that collectively? So an individual EMS organization might want to have some sort of arrangement with its PCI hospitals to go direct to the cath lab, or with the stroke patients direct to the CT scanner. That's something that's really outside the direct operational control of a given ambulance service. So inherently, they need to work at a systems level to do that. And if that hospital that has the PCI facility or the stroke lab interacts with more than one ambulance service, they need to get them involved as well. And so that's where you start sifting out, this is something that really needs to be addressed at a systems issue versus something that we need to address internally. And sometimes there's pieces of both. So you might internally have a process inside your ambulance service or fire rescue agency about how you get the 12 lead and how you make the decision about when to activate the cath lab by declaring a STEMI alert. But then the hospital will have its internal processes of once the STEMI alert is declared or the stroke alert is declared, how they work internally to make it happen. But the connection between the two, the way an EMS organization reaches out to a given hospital to declare the alert and activate that team, should be consistent with all of the ambulance services and all of the hospitals. So sometimes it's actually a hybridization of both approaches.
Thanks. I think you see where I'm coming from. This is like there was so much interest and so much excitement about last week. I didn't want to unintentionally make it seem like, okay, let's slow things down now and let's be hesitant to implement some of the things that were identified last week out of fear that we're going to affect things unintentionally at a system. It's wise to consider all that, but there's a whole bunch of stuff that would be well within the purview, for lack of a better example. So rather than switching engines, if we can all agree this is the engine we want, and EMS says, hey, we got a bent push rod, it would be more than appropriate for EMS to say, hey, let's fix this, or let's tune this engine up, as opposed to a whole scale kind of change and whatnot. So thanks. That's all I just wanted to make sure is that we didn't unintentionally put the brakes on anybody in their efforts to implement what you talked about last week.
It might take a little bit of time to soak in as well.
Yeah. So Tom, what about you? You got any questions or comments?
So I think the part that I was most interested in is the possibility of developing this time-sensitive care coalition. The way this all played out on Hilton Head Island is maybe 20 years ago we started taking acute STEMI seriously. And Tim, I think that's when we brought you in, is maybe 1999, maybe 2000, when we got LifePak 12s and we started transmitting ECGs to the hospital. And the technology back then wasn't where it needed to be. We had these strange black boxes that we had to plug into, and the failure rate was really high. The ECG would go to a fax machine, and in all honesty, they never activated the cardiac cath lab prior to our arrival. So, fast forward 20 years, and the technology is where it needs to be. They don't mind pre-activating the cardiac cath lab. And once we got STEMI figured out, and after the ACC did the Door to Balloon Alliance, and Mission Lifeline was doing their part, and hospitals got their door to balloon times way below 90 minutes, we kind of used that model that we used for process improvement, and then we kind of focused on resuscitation and out of hospital cardiac arrest. And then after that, we moved on to stroke. But you can't just keep adding quarterly meetings for every single diagnosis that you want to improve. Pretty soon you're going to be having completely separate meetings with all the top players, whether it's sepsis or stroke or anything else. So this concept that we could have one key meeting that encompasses all of the time-sensitive diagnoses is intriguing. So I guess, Mick, what I'm curious to know is, how would you start if you were a EMS chief? Would you just get together with your medical control physician and approach the key players at the hospital, maybe get the emergency department director on board? How would you start this coalition?
Well, I guess the first step would be to kind of assess what sort of meetings do you currently have. STEMI meetings are pretty common in a lot of areas around the country, but the real granddaddy of the time-sensitive care spectrum is trauma. Most everywhere there's a trauma meeting, although sometimes it's more at a state or regional level than a local level. But nonetheless, there are trauma meetings. Frequently you'll have STEMI meetings. Frequently you'll have stroke meetings or out-of-hospital cardiac arrest meetings, etc. So kind of take stock to where those groups are currently meeting and what their footprint is, so to speak, and start thinking through how might we bring these meetings all together with a steering committee structure, with the chairs of those different currently separate groups sitting on that chair, along with the higher level executive decision makers, C-suite people from the hospitals, EMS, fire, rescue, 911, et cetera, people that really have policy making authority beyond just clinical issues are appropriate to be on that steering committee. And that's where you kind of try to set the stage and manage expectations about, you're going to have some difficult conversations you're going to need to have. You might have already had some of those with trauma or STEMI or stroke, great. But just try to leverage that progress that the community might have already made in setting up these separate systems of care initiatives to bring them all together for the rationale we've discussed. And probably the medical director is already involved with that. Hospital emergency department directors will already be involved with them. But obviously it's going to be a heavier lift if you don't have any such
time-sensitive condition meetings currently taking place, and you're going to be starting with a clean slate.
Right. Well, so we do. I think a lot of times for some hospitals, the impetus to have these meetings might be Joint Commission if they're going for some type of stroke accreditation or chest pain accreditation, things like that. Part of their criteria is that they reach out and include EMS. And so that's one opportunity. If they ask you to come to a meeting like that, say, hey, well, as long as I'm here, maybe we should talk about other time-sensitive diagnoses. One thing, Mick, that I would do differently in hindsight, all these years later, about 10 years ago, when we first started taking resuscitation really seriously, there's this slide I show when I do presentations I always say these are all the stakeholders that were involved that finally sat around the table at the same time at Hilton Head Hospital. What I realized in hindsight, there was one stakeholder that wasn't there. There was no citizen representative. There was no patient representative, and we have one now. So I'm really excited to develop this time-sensitive care coalition and actually include a non-medically trained, he's actually a cardiac arrest and STEMI survivor that I would like to be on this coalition. So I'm excited to get started.
And it's interesting you mentioned that, because that'll be the person who inherently will be in a position to call people out when their proprietary interests are conflicting with patient and community interests.
I think the brilliance of that, Tom, is just, and Mick, you picked right up on it. It just, they might not even have to say a word. Their presence in the room, I think, would take the conversation in a completely different direction. So that's incredible. Well, hey, we have a question from John Bishop. And John asked, how can educational programs help their future EMS students to think about their part in the systems approach and the systems they can affect? Then he goes on, how can we train them to think this way?
Well, that's where I think having some content like we've been presenting in this webinar included in the initial training for EMTs and paramedics would be very useful. In our very first webinar that we did, I think it was November or December last year, AJ Heitman was our moderator, and AJ really picked up on that fact that we really need to include this sort of training in the initial paramedic and EMT schools, so that they come away with a better understanding of the whys behind our obsession about documentation and getting it to the emergency department in a timely manner for continuum of care reasons and for data reasons. And I just don't think as an industry we do a very good job of helping people understand the implications of great documentation and the implications of poor documentation, how that has a ripple effect. Although it assumes that the agency actually has some sort of a QI program and does something with the data, which is something that's a pet peeve of mine. We have a lot of agencies collect an awful lot of data, and I see precious little really being done with it. And that's also kind of the point of these webinars, is to get past that bottleneck I spoke of in these presentations. And the root cause I see is we have all of the energy invested in that one person, and there's just not enough bandwidth after all of those routine issues and other duties is assigned to actually get to doing the good stuff, the improvement projects.
Well, Mick, do you see any future resources that are maybe a light version of the full series of webinars that might lend themselves to the application that John is discussing, kind of something focused specifically for students or even providers, that to just really give them a kind of a bird's eye view of the whole thing?
Well, I would love to see educators watching these webinars and including some of the hopefully what they would consider pearls out of these presentations and including them into their curriculum. I recognize the reality that sometimes you've got an awful lot of content and a limited number of hours to do it. So it might fall upon the EMS agencies to do it through their new employee orientation programs and their continuing education programs. But one way or another, we need to get this message across. So thanks for asking that question.
We've got under 5 minutes left here. So as we kind of move to close some of this, Tom, do you have any final thoughts or comments before we begin to wrap things up?
Just that this information's coming at a really good time for me personally, because when I became the EMS chief on Hilton Head, one of the key things that I wanted to do, and I said so during the interview process, was to figure out what key bundles of care we wanted to deliver for each of the time-sensitive diagnoses. And so this is giving me a whole new way to approach the problem from a systems approach that I think my medical control physician is going to relate to. And from that standpoint, I think it's been extremely helpful. I know that part of the conversation, I remember I was a little bit surprised, Mick, when you said that you would invite payers to the table. Most people just can't stand payers and insurance companies, and the idea that they would take their cost savings and pass it along to you just seems almost impossible to most people, but reminded me a little bit about the EMS Agenda 2050's people-centered care, the concept that yes, we're here to treat the patient first, but we're trying to consider all the people, your own employees, the patient's family member, maybe the payers, all the different people that are involved in the totality of the patient's care. Have you really ever done that in a kind of a multilateral way, brought the insurance companies to the table?
Well, it works a number of different ways, but I can give you some examples of how that has happened in different parts around the country that I'm aware of. I think it was Houston. I don't recall the name of the hospital, but back when they were trying to implement CPAP, the hospitals really saw the downstream economic advantages to initiating CPAP on pulmonary edema patients rather than having them intubated by EMS in the field. And so instead of EMS having to bear that cost and not sharing in any of the financial benefits with shorter hospital stays, fewer nosocomial infections, all those sorts of things, the hospitals paid for the CPAP equipment and the disposables and saw a multiplier, such that for every dollar they spent on this for EMS, they saved X number of dollars plus on the other side of the equation. And you could see the same sort of thing apply to 12-lead technology, emerging stroke technology that's on the horizon, short of having a full CT scanner. There's an awful lot of tech being developed that will perhaps make stroke detection in the field a lot simpler. But again, EMS doesn't directly enjoy the financial benefits of that technology, but through these alternative payment models, it aligns everyone's financial interests. So it is happening, and there is a mechanism to make it happen.
Interesting. Yep. One step at a time.
Yeah.
Well, for Mick, folks that are in the Orlando area are going to be in the Orlando area. Before we part, could you just flesh out a little bit about that pre-conference that you alluded to?
Yeah, so this is with the National Association of City and County Health Officials at their annual meeting, and we're working with them to develop this model. And so we're going to start training up public health officials to help be the facilitators or conveners of these multi-condition time-sensitive care coalitions, and start doing some pilot implementations, et cetera, along those lines. It's not going to be, I think it's a half-day pre-conference workshop. So if anyone's interested, gave you the URL there, but it'll be the first one we do.
Excellent. Well, guys, we need to wrap up. So for more information, we've got the slide there. So the new EMS reporting service for AMI that's going to be coming out soon. So be looking for an announcement on a webinar that's just very specific for that. And that'll walk you through the product and provide the details on how to roll, the costs, and everything. In the meantime, you can visit acc.org at EMS Reports EMS for updates and to view prior webinars from this series, which I can tell you are incredible. Unsolicited comment. I have known Mick forever. I've been doing this for a little bit. I'm just, the old phrase, you don't know how much you don't know, clearly applies to me. And I just thank you, Mick, for all the work that you're doing in this.
Well, thank you. And I appreciate you and Tom
jumping on board and helping to moderate the session. I think you bring a lot of value to the conversation. We would love to address some more questions, so please don't be shy about sending emails to me so we can follow up and answer your questions offline. And certainly if you're watching the archive version of this webinar, do the same. Mick at improvethesystem.com, and I'll do my best to get back with you. So for people wanting to get a hold of Tim, you can see his email on the screen there, tphalen@mac.com. Tom has a bunch of different routes to contact him on social media. You can see his email address, tomb@hiltonheadislandsc.gov. Twitter handle is tbouthillet, LinkedIn as well, and just type his name into the person search engine there on LinkedIn, and you can find him there. And so on behalf of the American College of Cardiology and the Center for Systems Improvement, I appreciate everyone listening in, and please share this webinar and the link with your colleagues. And until next time, thank you very much. That concludes today's webinar.